Thank you. Appreciate the opportunity to come to talk today. One of the things that I want to start out saying that I've been involved with telemedicine for about 15 years at Texas Tech University, and I'm going to talk two components. One of them is the resource centers in general and what we're there to do, and then talk about how we utilize telemedicine from the university perspective in corrections. So we've got, I don't know if y'all are familiar with the state of Texas, but it's very large. And the university, we have about half of the state of Texas as far as our healthcare coverage goes. So when you look at the map of Texas, this little one right here, and I'll have a better one I think in a minute, we have 49% of the land mass, but we only have about 12% of the population that live on our side of the state. And so very diverse area. But when you talk about corrections, you know, there's 1.5 million people incarcerated right now across the United States, and they're all guaranteed access to basic healthcare services. The only people that are guaranteed that access to care, which is, you know, kind of sad, but we have to do that. In Texas, we've got one of the largest prison systems, unfortunately, because we're so big. There's about 150,000 incarcerated. We have about 33 to 35,000. It kind of varies from month to month sometimes because as they move people around. But we have about 33,000 on our side of the state. We've got 15 of the correctional sites set up with telemedicine units. And in 2013, we saw a little over 9,100 patients through telemedicine. Most of that is in mental health services, but we do a lot of different things with it. When we started looking at trying to develop telemedicine and what the possibilities were, okay, sorry about that, we'll go back to this. We had already been doing telemedicine in a rural area down in the Big Bend area in Alpine. And so when we got the correctional contract with the state, we started looking at, okay, how do we do this? At first we were sending physicians out and they were actually driving out to the prison units and seeing patients in person. And we started tracking how much window shield time, as we called it, that they were actually taking up just on the road traveling to these sites. And you can see the numbers here. It was just the hours that we were wasting for those providers to travel out was just huge. To the point where when we dropped it down and started developing our telemedicine programs in corrections, we actually got to hire 2 additional FTEs to provide services for the cost savings in travel alone that we were saving. So it was huge on what we did as far as implementing it in. This is the side of Texas that we cover, 108 counties. We've got a community-based program right now. We've got 20 community sites plus the correctional sites that we deal with on our side of the state, and do it quite well, actually, I think. The number of consults has increased tremendously since '94 when we opened up our first correctional site. And I think we're on track to see about 11,000 inmates this year. That's what our projections are if the numbers stay.
Is that mostly UTMB?
No, this is all Texas Tech. In Texas, there are 2 components for correctional health care. Texas Tech has the western side of the state. UTMB has the eastern side of the state. So this is all just what we're doing out of the university at Texas Tech. So, and they have about 120,000 to 130,000 inmates on the eastern side that they take care of for corrections. So their numbers are really large in the correctional setting as far as telemedicine goes as well. Some of the statistics, this is what we do the most of. Obviously mental health services are easy to do, but we also do a variety of medical services. Dermatology, urology, and internal medicine are the top 3 services that medical services we're providing. You know, one of the things that we also keep track of is by the telemedicine encounter, how many patients we can keep from being transported out. And since 1994, we've been tracking this average of 85% of the encounters. We keep those inmates in their unit as opposed to out on the road traveling. So we think that those numbers are huge. When you look at what the cost savings are, we estimate that it costs about $350 an inmate to transport them out. If you looked at the number of inmates that we saw in 2013, and you did that by the $350, I mean, we saved over $3 million just in transportation cost. That includes 2 guards, the vehicles, the gas that goes in those vehicles. So that's a pretty big number that we've saved the system by not transporting those patients. If you look at all the encounters, it's about $15 million that we've saved since we started doing this, just in transportation cost alone. So that's our correctional program. That's why we do it. We say it's the savings, but not only just in transportation costs, but the security behind it. I mean, we don't want those inmates out on the road traveling. Inmates also like to be seen over telemedicine because when they leave their unit to go get health care, there's no guarantee that they're going to go back to the same unit that they got transported out of. And so there is an incentive for them a lot of times to be willing to be seen over telemedicine because they don't want to leave their facility where they're used to, have to pack up all their stuff with the chance that they may not go back. And the reason that they do that is a security issue, because if an inmate knows that they're going to be transported out and they're going to go back to that same facility, they might try to figure out how to do an escape, have somebody come break them out. I mean, there's a lot of security that goes in that. And so that's why a lot of times when they want to shake things up, when they're transporting for health care, they'll send them to another unit. Especially if they're a problem inmate to begin with. It's a easy fix as far as that goes. So the inmates really want to be seen through telemedicine to keep all that kind of stuff from happening. I'm going to talk about the resource centers now, but I'm going to stop. Does anybody have any questions on the correctional side of things?
Do they have a choice?
To
be seen via telemedicine or traditional?
No, actually, they don't. Because we provide access through telemedicine. I mean, they have a choice to be seen or not to be seen. We're providing them primary care access, and so the rules don't say that it has to be in a face-to-face encounter, or if we can do telemedicine, because we state that telemedicine is the same as a face-to-face. So that's how, we give them the choice. You can be seen. If you want to be seen, it's going to be over telemedicine, at least initially.
Does that mean you don't make them sign waivers specific to telemedicine?
They sign a consent form to be seen, and they can decline. There's on the consent form that we give them, there's an area that says I decline to be seen through telemedicine, and it goes into their file. And so if they change their mind, then they can come back and sign another consent form. But they have to agree or not agree and sign the consent form that says that.
Do you know what kind of percentages are saying no?
Very few, half of.
2,000.
Exactly. I mean, I think in the 15 years that I've been doing this, I can think on one hand how many inmates that we've had decline being seen. So, because it was through telemedicine.
Debbie, have you got any data on, the better outcome by a patient being seen more readily by telehealth than waiting for the prison bus a week later?
Well, for mental health services, it's huge. I mean, we are providing those services in their community that they feel comfortable at, and they're getting obviously access a lot quicker, and so emergent type stuff comes up. We can get them in front of a psychiatrist a whole lot faster than we could if we had to wait for the bus to transport them. And so when you're dealing with mental health especially, that's huge. On the medical side of things, getting in to see a dermatologist face to face, I don't know how many of y'all have tried to get in to see a dermatologist. You're talking, sometimes 6-month wait to get in to see a dermatologist? Well, we have a standing dermatology clinic every Thursday afternoon at 1 o'clock that I have access to those. And so I can get a patient, whether it's a correctional patient or a community patient, I can get them seen a whole lot faster through telemedicine than I can if we were trying to schedule them face to face. So in that sense, we're actually able to catch things a whole lot sooner than if, suspicious moles that might be melanomas or anything like that. And that happens a lot with the correctional guys because they're out in the fields working during the summer, and, access to sunscreen is a hit or miss as far as that goes. And so we get a lot of those type of cases. And so the quicker that we can identify those situations, the sooner we can get them treatment so it doesn't go on to something more serious.
How is the dermatology done as far as the imaging and the quality of the images?
We have,
You have like a device that sends it.
we have everything that we do is live interactive because that's what we have to do in Texas. So we don't get to do store and forward. It's not recognized as a reimbursable entity through in the state. And so we actually have dermatological cameras where they can zoom in, get a close-up of the skin. We have electronic medical records so they can actually capture that image, save it to the medical chart, and then the doctor can do a before and after comparison to see as they move forward if it's growing, if it's getting better, those kind of things.
So
So,
nurse is doing it?
pardon?
Somebody like a nurse is doing
Yes,
it?
we have in Texas. You have to have a certified healthcare provider presenting the patient. So we have LVNs, RNs are normally the ones that are presenting the patients in the correctional setting. On occasion, we'll have one of the primary care providers step in and want to do it, especially if it's a case where they're just not real sure about, because they're using it as an educational and teaching opportunity to learn, so the next time somebody comes in and presents with the same type of diagnosis, that they've been able to talk to the specialist and they're able to take care of some of that better themselves without having to resort to seeing the specialist as they move forward.
There's a security risk for them, obviously, huh?
Yes. So
They get paid for that.
just a little bit more, but really not enough in my opinion, unfortunately. So I don't know if y'all have ever been into a correctional facility, but it's an eye-opening experience.
Imagine.
So one that I don't like to have to do very often. And I'm glad I have my get out of jail free card to get me out. So, but when you walk up to the prison, and you see on the door to get into the facility that says no hostages will leave this facility, you understand how serious it is. So anytime that we can keep everybody safe, the better off we're all going to be as far as that goes. The other thing I wanted to tell y'all about are the telehealth resource centers. There are 12 of us. There's 12 regional resource centers and 2 national resource centers. And I'm going to ask, do y'all know who your resource center is? Do y'all know what a resource center is? Who knows what a resource center is? Well, resource centers, we are federally funded through HRSA to provide technical assistance to anybody interested in developing or expanding telemedicine. Each part of the U.S., we all have a certain area. I happen to cover Texas and Louisiana, but we are federally funded to answer questions, to help guide anybody that wants to know, what the policies are, what reimbursement is, things along those lines. That's what we're funded to do, is to provide that assistance. We work a lot with rural and underserved areas, but we can also work with anybody that has questions. We don't worry about that. But one of the things that why we do what we do is because 16% of the population live in rural areas, but we only have 9% of the providers that work there. So, this is huge when you think across the United States. Texas ranks 48th, Louisiana's 23rd in the number of primary care providers. And, those numbers are that way across the board. When you look at all the different states. But the biggest reason why we do what we do is we have 28 counties in Texas that have no primary care provider, no physician of any kind practicing in those counties. But what's even more amazing is we have 12 counties that don't have a physician, a nurse practitioner, or a PA. And in some of those cases, patients are traveling 90 miles one way for primary care service when we could utilize technology. I mean, the exhibit hall is full of technology options to be able to provide those services to those patients. And when you think about healthcare, and we've got Obamacare and everybody says, okay, we're going to get everybody signed up for insurance. Well, just because they have access to insurance doesn't mean that they have access to healthcare, because it's not guaranteeing them access to healthcare. It's guaranteeing that they have a card that they can take in and say, I have insurance. But if you live in rural America, if you're one of the 16% that live in those areas, you could have 100 cards, but that doesn't mean you have access to health care. And so that's why we do what it is that we do, and that's what the resource centers are here to help promote, is why we do that.
Do the resource centers ever, because the ATA, so recently in Tennessee we had a rule that they're trying to pass, the hearing's actually this afternoon, to make it harder to do telemedicine. Do the TRCs help try to fight against that, or as a federally funded body, do you guys stay out of that?
We don't. What we do is we go in and try to educate. I don't go in and say as a TRC, I don't go in and say, hey, your legislation that you just bill is bad. I don't do that. What we try to do, and what we've really done as a group of TRCs, is we've sat down and looked at those policies. The latest one is the state medical board's new ruling that they put out. Their federation put out a document that said, this is what we would recommend all states' medical boards follow these policies. Well, we took that, analyzed it as a group, and said, okay, we're not going to tell you that you're wrong, or we're not going to tell you need to change this, but what we did is say, this is what the effect of some of this language would have on the healthcare outcomes of other people. And so I spent a lot of time last year in Austin educating the legislatures about what telemedicine is, not necessarily telling them that some of what they were trying to do was wrong, but letting them understand the negative impact some of the language could have had in the particular case like you're talking about, where it's going to have a negative impact on what it is that we're trying to do. And so that's what the TRCs do. We can go in and we can help provide language to people to take and say, this is why you don't need to be doing this, or this is the negative impact that it would have if you go through with a certain bill. So we're here to do those kind of things. We're there to provide, just be a general resource. If you got reimbursement questions, you're thinking about doing a particular service line, is it something that could be done? Who out there is doing the same type of things, so we can connect you together? Because ultimately, there's no reason to reinvent the wheel. If there's somebody already out there doing something that you're thinking about, we can put you together, and we have that ability. If we don't know something, if I don't know something, we've got our internal workings with all the resource centers, put it out on the listserv, and within 5 minutes I've got about 15, answers from everybody else telling me, this is what you need to do, this is who you need to talk to, and this is where the information is. So,
just a moment, when you talked about the Federation of State Medical Boards policy guidelines for telemedicine, what were the areas that were most impactful?
There's language in there that has to do with phone calls, physicians providing phone care services, and that seemed to be the hottest topic of anybody, was what constitutes adequate service. And will a phone call or a fax or an email, does that actually constitute good quality medical care? And there's debate out there, depends on who you talk to, whether that's good or bad. State Medical Board in Texas says, what, we can develop the physician-patient relationship through technology, but you got to have that interactive video. You got to be able to, the provider has to be able to see that patient, see their facial expression, see how it is that they're interacting with them, to be able to develop that. A phone call, an email, to develop that relationship doesn't work. Now, if a patient comes in and gets seen and the doctor wants to call them and say, hey, I've got your lab results, that's okay, that's acceptable. But developing that initial one-on-one through a phone conversation in Texas is not allowed. Louisiana is the same way. So, I mean, there's a give and take. Mixed opinion on whether that's good or bad. I mean, ultimately, what we want to do is want to make sure that patients are safe, but they still get the care that they need, but it's done in a safe manner. Okay? Mm-hmm.
How do you handle like second opinions, or if they want to see a specialist? How do you do that?
Well, really, the majority of what's done through telemedicine is access to specialty care. So whether it be mental health, psychiatry, or access to the dermatologist, urologist. I mean, across the United States, that's what the majority of telemedicine is used for. It's not used for primary care in most cases. Now, we've got a couple of school-based health systems that we work with where they've got a school nurse and we're providing services and giving them access to specialists, either primary care or specialty care from the schools. So, we have to follow the same rules and regulations as anybody would if a patient was being referred to be seen in person. We're just being provided the modality to get them seen. Okay? This map kind of shows across the U.S. where all of the health professional shortages areas are. And I can't remember the exact numbers, but there's something like 5,200 health professional shortage areas across the United States, and it would take, there's like 55 million people living in those health professional shortage areas. It would take over 15,000 primary care providers just to meet all of the healthcare needs for those people that are living in those areas. And unfortunately, the number of individuals going to medical school right now is decreasing because, they're not sure how they're going to get paid. They're not sure what the effects of Obamacare is going to be. I mean, things are very up in the air as far as that goes. And so those numbers are not going to get any better anytime soon. Mental health is another area where we have a lot of shortages. And last count in October, it would take an additional 8,000 mental health care providers to meet the mental health care needs across the U.S. So, I mean, we've got huge numbers that we've got to figure out how to do that, and technology is the only way that we're going to be able to do that. And this is my last slide, and this says it all to me. I mean, wouldn't it be nice that you could get access to your healthcare provider anytime, any place, anywhere? Technology is not the problem. Technology is easy. That's the easiest part, really, when you come down to it. It's figuring out how to bring the patient and the provider together through all the regulations that we have to deal with. And so, there will become a time where you can be in your office, you can be at home, you can be wherever, and you can have a telemedicine kit that you carry with you, or with a web camera and secure software, and you're going to call into a call center, and it's going to be housed by a nurse, because when you go to see the doctor, who's the first person you see? It's a nurse, okay? She does your vitals, she asks you what you're there for, verifies what kind of medication you have. Same thing. It's going to happen, only we're going to do it through technology, and they're going to determine what the next step is. But it's all going to be done through technology. So, anybody have any questions? Thank you very much.
Thank you, Debbie.
Thanks, Roger.